Morning. Today my topic is breathless moments, navigating anesthesia in the emergency removal of a bronchial foreign body. Now we will go about this presentation in the following headings. First the case presentation, then the clinical presentation, the pathophysiology, the anesthetic concerns, and then the anesthetic management. So coming to the case history, here we have a 9-year-old male child weighing 25 kgs. He had a history of pen plug aspiration. As you can see, the end plug of the pen 4 days ago. He was asymptomatic initially, but productive cough began 2 days ago. No other positive history. He is a normal school-going child with normal scholastic performance. So on general examination, he was slightly anxious. He had a respiratory rate of 20 per minute with regular respiration and no stridor. He had an SpO2 of 97% on room air. Respiratory examination. On inspection, it was an abdominothoracic type of respiration. The chest expansion was reduced on the left and there was no stridor or accessory muscle use. On palpation, the trachea was central, and on auscultation, there was decreased air entry in the left lower zone and conducted sounds and rhonchi in the left lower zone. The other system's examination was normal. The airway was also normal. On investigations, the chest X-ray showed a mild hyperinflation of the left lung. The CBC profile, all investigations were normal. So, based on history, physical examination and X-ray, we concluded the diagnosis as a foreign body aspiration, a suspected partial obstruction in the left main bronchus. Now coming to the discussion of a foreign body bronchus, the clinical presentation in general. If the foreign body is stuck in the bronchus, the child may have coughing, wheezing, dyspnea, air trapping, or chronic infection. If it is in the trachea, which is a warning sign of danger, it's rare but it will cause complete obstruction, a bidirectional stridor, a change in voice, or even cyanosis. Now coming to the pathophysiology, if it is an organic foreign body, it tends to swell up with time and could change from a partial obstruction to a complete obstruction. A chronic foreign body tends to move downward and outward. Foreign bodies may also tend to fragment and dislodge itself into smaller airways. They may also produce an inflammatory response and further complications like granulations or strictures. So the bronchoscopy is considered an emergency if the child is in severe distress or if it's a tracheal foreign body causing complete obstruction, if it's an organic foreign body, or if the foreign body is a sharp object. We can wait for nil per oral of the child if the child is stable, if the child presents late, delayed presentation, or if it is confirmed that the object is firmly lodged beyond the carina. Now coming to the anesthetic considerations for a child coming with foreign body bronchus. There will always be a sharing of airway between the anesthetist and the surgeon. Hence, there is a risk of hypoxia which may lead to intraoperative cardiac events. There is always a displacement of foreign body down the airway. The risk is always there. And there is a risk of airway trauma during the instrumentation and manipulation. There is also a risk of perioperative respiratory adverse events like laryngospasm, bronchospasm, persistent coughing, or rapid desaturation. Now coming to how preoperative preparation in our case. A high-risk consent was obtained from the parents, NPO status of the child was confirmed, a post-operative PICU bed was reserved, pre-medication was avoided, nebulization with salbutamol was given in the pre-operative area, injection hydrocortisone 5 mg per kg was given, the child was taken inside the OR and standard ASA monitors were attached. So the surgical plan was to use a rigid bronchoscope and remove the foreign body, and our anesthetic plan was general anesthesia with controlled ventilation. So here you can see the various types and various sizes of the bronchoscopes which are arranged on the trolley. This is the forceps which is used to grasp the foreign body, and this is the catheter mount which is used for ventilation intraoperatively. So here we can see the following video which shows the intraoperative management. We have already connected the nasal prongs. We are giving fentanyl 2 mics per kg, propofol 3 mg per kg. And then we are bag and mask ventilating. You can see the nasal prongs which have already been attached previously. So the chest rise is confirmed. We are adequately oxygenating the child. You can see the chest rise clearly. Meanwhile, the surgeon is getting the bronchoscope ready. Next, through direct laryngoscopy, the vocal cords are sprayed with lignocaine spray 1 mg per kg under direct visualization. After the spraying of the cords, we again continue to ventilate until the surgeon is ready. The surgeon then gives the extended position. A bolster is inserted below the shoulders. The surgeon does direct laryngoscopy, and then the bronchoscope is inserted by the surgeon, and then we attach the catheter mount to the bronchoscope so that we can continue our ventilation throughout the procedure. Here we used a TCI pump, PET fusor model, propofol 1% intraoperatively for maintenance. Now you can see in this video, so the surgeon is first in the trachea. They go towards the right main bronchus where there is no foreign body seen. Then you can see when the surgeon goes towards the left main bronchus, there is a blue glistening structure along with pent-up secretions. This is the foreign body, that is the end plug of the pen, which was seen intraoperatively. In this video, you can see that we have brought the pen plug from the left main bronchus up to the trachea. It was stuck just below the vocal cords. Multiple attempts have been made in order to retrieve the foreign body, but because of the pent-up secretions, because of the hyperemia, because of the slippery nature of the foreign body, it was very difficult in order to navigate this foreign body from below the vocal cords and pull it to above the vocal cords. So here, probably throughout the procedure, we assume that the small hole on the rear end of the pen plug probably kept the ventilation ongoing, and hence no significant desaturation episodes occurred intraoperatively. There was a difficulty in navigating the rigid bronchoscope along the foreign body beyond the vocal cords. So there were various surgical instruments were used along with manipulation in position. After 2 hours, the foreign body was removed by the surgeon along with alligator forceps. Check bronchoscopy was done on the right side as well, and no residual foreign body was confirmed. But due to paradoxical respiratory movements and subglottic edema due to extensive manipulation, the child was intubated with a 5 uncuffed tube because 5 microcuff could not be passed, and the child was sent to PICU for elective mechanical ventilation. So post-operatively, nebulizations were continued 4th hourly. A post-operative chest X-ray was done, which was normal. Dexamethasone 0.5 mg per kg TID for 2 days was given, and after the return of good, adequate, spontaneous respiratory efforts, the child was extubated on post-operative day 2. So, we must remember that there is always a possibility of dislodgement of the foreign body during retrieval. The foreign body may become snagged and dislodged at the cords or larynx, causing severe or complete airway obstruction. Due to bronchial edema of the affected side, the object may fall into the good lung, thereby compromising gaseous exchange. If the object becomes lodged in the trachea, the foreign body needs to be retrieved rapidly. If this is not possible and severe desaturation occurs, the foreign body may need to be pushed down one bronchus to allow some amount of gaseous exchange. Occasionally, an emergency tracheostomy may be required, and preparation should be made for this before the start of the case. So here we used controlled ventilation, and the main advantage of this is that it provides an immobilized airway and a good surgical working condition throughout the procedure. The main disadvantage is that there is always a possibility of the foreign body moving distally. In case of spontaneous ventilation, there is a lower risk of the foreign body moving distally, but there is always a chance of inadequate depth and more chances of perioperative respiratory adverse events occurring. The other ventilation strategies which can be used are apneic oxygenation, high frequency positive pressure ventilation, ventilating bronchoscope, or a Venturi injector device or a Sanders device. So the complications which can occur throughout the procedure, first it might be a laryngeal edema or an injury during instrumentation, a type 1 negative pressure pulmonary edema, or a complete airway obstruction. There may also be hypoxia, hypercarbia, aspiration of the gastric contents if the child is not NPO, pneumothorax or pneumonia, which may lead to arrhythmias, cardiac arrest, or because of hypoxia or hypercarbia, there may be seizures. So newer research is being conducted on the use of transnasal humidified rapid insufflation ventilatory exchange in the foreign body retrieval, the use of mechanical jet ventilators, and the use of dexmedetomidine, as it provides adequate analgesia and sedation without significant respiratory depression. So to conclude, a normal chest X-ray does not rule out a foreign body. Any suspicion, it is better to do a bronchoscopy, as it is better to have a negative bronchoscopy rather than missing a foreign body. Always be ready and well equipped even for a tracheostomy, and a thorough pre-anesthetic evaluation and a meticulous management of the airway prevents any catastrophe from happening. So these are my references. Thank you.